Medical Service Company has over 30 sleep coaches supporting more than 50,000 patients to refresh their CPAP supplies, troubleshoot equipment, and promote compliance. With each call, we review the importance of refreshing supplies to prevent bacteria buildup and to promote healthy compliance. Most insurance companies allow supplies to be refreshed every 90 days. We have 2 programs to refresh supplies, and patients can choose which one they prefer. The first is our Courtesy Contact Program, where patients receive a call, text, or email as they become eligible to refresh their CPAP supplies. The second option is our AutoShip program, where supplies are shipped to the patient based on the schedule recommended by their insurance company. We also assist patients daily who have received their CPAP from another provider and would like to receive their supplies through our refresh program. To order supplies for any CPAP patient or to learn more about our MSE Sleep Refresh program, please visit medicalserviceco.com/refresh.
Good morning. I hope you're enjoying this session so far. Hopefully everyone has already submitted the evaluation for the previous 2 lectures. As a reminder, you need to complete and submit an evaluation after every lecture. Our next lecture will be presented by Dr. Navin Jain on residual sleepiness after PAP treatment of OSA. Dr. Jain has a clinical sleep practice for over 20 plus years and is board certified in internal medicine, pulmonary disease, critical care medicine, and sleep medicine. Dr. Jain completed his undergraduate and graduate studies in New Delhi, India at Maulana Azad Medical College and his internal medicine residency at Cook County Hospital in Chicago, Illinois. His pulmonary fellowship was completed at the University of South Florida, while his critical care fellowship was completed at the University of Massachusetts. Dr. Jain is a member of the Ohio State Medical Association, the American College of Chest Physicians, and the American Academy of Sleep Medicine. We appreciate Dr. Jain for participating and sharing his lecture during our educational forum. As a reminder, if you have questions that come up during the lecture, please enter those under the Engage tab, and Dr. Jain will address them following his presentation.
Thank you very much for giving me this opportunity to talk about residual sleepiness after PAP treatment for obstructive sleep apnea. I thank Mary Carusoli and Alison Patrick for giving me this opportunity. And hopefully this will be an enlightening talk for everyone. Most of the time I talk more of an interactive talk. So if the talk say, how many of you do this thing or that thing, maybe you can just raise your hand even if you're sitting alone to have a feel of it to see if you participate in these things or not. Looking at the objectives of this talk, number 1 is to understand the mechanism of sleepiness in obstructive sleep apnea. Number 2, how to proceed with the workup of patient with residual sleepiness in patients with obstructive sleep apnea who has been treated with positive airway pressure therapy. And number 3, how to manage residual sleepiness in this group of patients. Do not have any conflict of interest related to this topic. So obstructive sleep apnea, as you know, and this is illustrated with this cartoon, is obstruction of airflow with a collapse of the nasopharyngeal muscles. In the top portion of this cartoon, you see in the blue airflow going from oropharynx and nasopharynx and going into the trachea. Whereas because of nasopharyngeal collapse of the relaxation of muscles, airway is blocked and the airflow does not go through. Because of which several things happen, which we'll talk about it in a few minutes. So most of the time, when we see somebody with obstructive sleep apnea, what's the reason one of these patients will present? Probably snoring and witness apneas, gasping for breath at night is the most common symptoms, I would say. Sometimes we'll get patients with history of difficult to treat hypertension or a recurrent atrial fibrillation or other cardiac arrhythmias that would be referred to rule out any sleep apnea. Uh, Sometimes people will present with tiredness or sleepiness. Pre or post-operative for reason. Sometimes for bariatric surgery, pretty much always do a sleep study to make sure these people do not have sleep apnea. Sometimes people go for any kind of surgery and their anesthesiologist may notice this person is snoring or had some issues with intubation or extubation and recommend sleep study and further workup. Employment related, most of the time you're seeing in commercial driver. I've had few people who work for air traffic controller and in nuclear energy industry, where because of their neck circumference size or body mass index, they're recommended that they be tested for sleep apnea. So when we do the testing, currently, majority of the time, I would say 85, 90% of the time, the diagnostic study is a home sleep study. Most of the time, that is enough to diagnose, and I'll not go into details of that. And the treatment, again, most of the time is an empiric auto-titrating CPAP machine. And if a person doesn't tolerate that, maybe switch to a bi-level positive pressure machine. But rarely when an insurance may allow diagnostic polysomnogram for other comorbid condition, then one may be able to put them on a different treatment if indicated. So looking at the positive pressure therapy, what we use in these patients is again is a continuous positive airway pressure, which could be fixed pressure or auto titrating, on bi-level, which could be fixed auto titrating or with a backup rate or an adaptive servo ventilation. Now, a few of the treatments that are available for obstructive sleep apnea are one is an oral appliance therapy, which is recommended mainly for patients with mild sleep apnea who are symptomatic and do not have any issue with the weight. Number two, upper airway surgery. That's done very, very rarely these days. A maxillomandibular advancement where it's done by oral surgeon and it has got a good success rate, but is a pretty extensive surgery. And recently, there has been interest in hypoglossal nerve stimulation for treatment of sleep apnea in people who are refractory to the positive pressure therapy treatment or cannot tolerate it. So, what is sleepiness or inappropriate sleepiness? Pretty much what it means. Sleepiness when person should be awake. So they're unable to maintain wakefulness and alertness during their major waking episode of day. It could occur intentionally or at inappropriate times. It should be unintentionally, sorry. There's a typo on that slide. They're at a risk for work-related or motor vehicle accidents. Most of the time, we take patients' word. They fall asleep and they're not active. There are certain objective tests we have used. Epworth sleepiness scale is probably most common and most people are aware of it. Number 2 is Karolinska sleepiness scale, and I'll go over that in a minute. And third is a multiple sleep latency test, which is done in a sleep lab and which requires an overnight sleep study. And because of all those things involved, that's rarely done to assess sleepiness. So Epworth sleepiness score is an estimate of person's average sleep propensity across a wide range of activity in their daily lives. So person graded from 0 to 3 different activities, and this is not at that particular time in general. Sitting and reading, watching television, sitting inactive in a public place, as a passenger in a car for an hour, lying down to rest in the afternoon, and sitting and talking to someone, sitting quietly after lunch in a car while stopped for a few minutes in traffic. There's some downsides for it. Again, it's subjective. Other things could be that some people, it may not apply. Person may not be going in a car for an hour without a break, or may not drive at all, doesn't drink alcohol, so sitting quietly after lunch with alcohol, um, doesn't take a nap. So the score may not always be perfect. Karolinska sleepiness scale is looked at that particular moment how a person is feeling. Again, most of the time, patients in your office, they probably will not be 10. Most of the time, if they're sleepy, it might be 4 or 5 or 6. So again, these scores, these scales are not very well validated, but this is the best we have. There is another thing that is out there to assess the impact of sleepiness. Because these scores are not perfect, so some people started looking at what is tiredness, sleepiness is causing in these people, and that may help them figure out. Because as you know, we have seen very many patients who come to the office, they say they're not sleepy, but then they're put on a CPAP therapy, and once that's done, they feel, oh, I feel great. Although they did not have much problem to begin with, they came only because they were snoring. there are 30 questions in this functional outcome of sleep questionnaire, FOSQ. And I'm not sure if any of you have been using this in your practice. I know that I have not been using it, but I'll look into using it. These questions are related to general productivity, social outcome, activity level, vigilance, intimate relationship, and sexual activity. So with these questions, people answer again on a scale of 0 to 4, and then these scores are tallied, and then see if the sleepiness or tiredness or whatever they feel is having an impact on their functional outcome. Now, many patients with obstructive sleep apnea may not complain of sleepiness, may just complain of fatigue, some lack of energy, lack of ambition, excessive consumption of caffeinated beverages. So those kind of things one may need to ask beyond just sleepiness or looking at Epworth sleepiness score. Now, sometimes these patients may not feel sleepy, but all these things going on because that's their personality. They are always on the go. So they never feel they're sleepy, but all these other things are going on. And like I said earlier, they may feel much better after starting to use positive airway pressure therapy, although they never complained of sleepiness. So switching gears a little bit, why people in obstructive sleep apnea are sleepy? Again, like anything else, it could be multifactorial. The mechanism is not fully understood. One thing that's suspected is insufficient sleep duration, which may or may not be related to sleep apnea. It may be related to multiple arousals during the night. Intermittent nocturnal hypoxia, as it'll happen in obstructive sleep apnea. This could persist over the years and may cause some daytime cognitive dysfunction and damage to wakefulness promoting neural networks. There is a sleep fragmentation and arousals, so people cannot go back to sleep as quickly. Some autonomic dysregulation on abnormal sleep architecture that we see, multiple arousals, multiple changes in the sleep stages, and chronic inflammation and cytokine productions. So, in essence, everyone with obstructive sleep apnea is not sleepy. Why? We don't know. We did find that sleepiness is somewhat more common in people with symptoms of anxiety and or depression. Another thing we found was that severity of obstructive sleep apnea based on apnea-hypopnea index does not correlate with a tendency for sleepiness. So there were some animal experiments done in early 2000 with mice, and one group reported their findings in 2004 in Sleep Journal, where adult mice were subjected to long-term intermittent hypoxia, which they were modeling the same thing as happens in obstructive sleep apnea. And they found that these mice had increased sleep time and objective sleepiness for several weeks after they were back in normal oxygen condition. Now, another author from the same group did similar study, and they did chronic sleep deprivation, and they noted reduction in wake active neurons in locus coeruleus by 50% and oryxogeneric neurons by 25%, and these are all involved in wakefulness. So in human, there were a couple of studies that they found. In 2012, they reported where they did MRI changes saw in patients with obstructive sleep apnea, and they noticed some changes in the frontal lobes, and they felt that after 6 months of positive airway pressure therapy, these changes were not reversed. Although some changes happened in hippocampus also, those were reversed. Although they did not correlate these well with the sleepiness, but they did infer that some changes may never recover or may recover very slowly. In 2010 in CHEST, they presented another findings using diffusion tensor imaging, which showed changes of white matter abnormalities, some improvement in 3 months and complete reversal in 12 months. So all the damage that happens to brain structure and function in people with obstructive sleep apnea, some of it is reversible and reverses over time. Very little things reverse rather quickly. And then some may never reverse completely. So when we look at people with sleep apnea, what could be the other reasons for sleepiness in these patients? Certainly, they could have narcolepsy or idiopathic hypersomnolence. We talked about insufficient sleep syndrome, restless legs, periodic leg movement disorder. One could have frequent arousals because of pain, gastroesophageal reflux disorder, could be stress incontinence, or prostate-related urinary frequency. Certain medications could make someone sleepy. So all those things need to be kept in mind. So what's the effect of positive airway pressure therapy on sleepiness in patients with obstructive sleep apnea? So some patients will come back and say, oh, they are literally transferred overnight. They wake up alert and be productive all day. There was a study published in 2013 where patients with moderate to severe obstructive sleep apnea and abnormal Epworth sleepiness score 2/3 of them had normal Epworth sleepiness scores at the end of 3 months when using positive airway pressure therapy for more than 5 hours. Now, they could still be sleepy when they had sleepiness to begin with, despite their AHI on the CPAP download is less than 5 and they're sleeping at least 7 hours a night. In general, it's felt that about 16 to 14, maybe average about 10% people will have excessive sleepiness after being optimally treated with positive airway pressure therapy and excluding confounding causes of sleepiness. And substantial proportion of patients will never normalize their neurobehavioral response despite adequate positive airway pressure therapy. So this is a meta-analysis of studies. There were 11 studies they took in there and saw the data. So in this meta-analysis, they use Epworth sleepiness score to assess sleepiness before and after positive airway pressure therapy. In figure 1, this is that looking at all the studies where they found reduction in on an average of 2.87 change in Epworth sleepiness score. Some studies had more and some had less, as indicated on the graph. And in figure 2, looked at the patients with severe sleep apnea who initially, on initial study, had an AHI of more than 30. On their mean effect was 2.94. So one of the risk factors for residual excessive sleepiness in obstructive sleep apnea, it's again not very well defined. If they have severe excessive daytime sleepiness at the time of diagnosis and a low apnea-hypopnea index at diagnosis, those are probably at a higher risk, and probably the reason might be that they have some other reason for their excess daytime sleepiness. A younger age, a lower mean duration of positive airway pressure use, meaning number of hours they're using. If they have associated depression, if they have some issues with positive airway pressure therapy, or on the sleep study, they had reduced sleep latency and had periodic limb movement disorders. So when somebody has residual excessive sleepiness after adequate treatment of sleep apnea, to evaluate these patients, one need to go back to the drawing board. First step will be to confirm the original diagnosis of sleep apnea. One may need to go back and review the original study to see if it clearly shows sleep apnea or not and was obstructive in nature. especially if the therapy was done empirically using a positive airway pressure therapy. If initial diagnosis is based on a home sleep study, one may consider doing a polysomnogram, just because that home sleep study may not have picked up on other abnormalities, including periodic leg movement disorder, arousals, early REM sleep, possible narcolepsy, uh, possible central sleep apnea. One should also consider diagnosis that can cause excessive sleepiness. And third thing would be to confirm the adherence of prescribed positive airway pressure therapy, and that probably is the first thing rather than the third thing, which could be historical, looking at the patient, talking to patient, getting information from the patient as well as from the bed partner, or looking at the PAP download data. Now, PAP download data, there are several things that are available in this data. One can look, and I have this slide showing a compliance report from a patient in Airview, where it tells you how many days somebody has been using, what's the average length of time they have been using, what's the apnea hypopnea index, and any leak. Now, in this patient has been using about 7 hours and 47 minutes on an average. Apnea hypopnea index is 0.2. There is minimal leak, which is on the right-hand side, and the yellow is the leak. I'll come in a minute to a few things that these reports don't tell us. Now, this is a report from Respironics, where I think I don't have the graphic sheet on the other one, but it does tell you about similar thing, how much time in the large leak and the average number of hours in AHI. So the information obtained from PAP download is not uniform. It tells you the duration of use, which can be from daily and up to 1 year, but it's not same as sleep time. Because somebody is using for 4, 5, 6, 7, 8 hours, doesn't mean that person is sleeping all the time. So that's something one needs to question patients to see how much time actually they are sleeping. Again, the compliance criteria created by insurances are not same as a sufficient sleep. A person who could be compliant, which is more than 4 hours a night, but needs definitely much more number of hours of sleep to feel rested. Apnea-hypopnea index on a PAP download. What's the significance of that? I really feel that it does not correlate well with the sleep studies. I've had several instances where it showed a high apnea-hypopnea index in central events, and then when we send these patients for the sleep study, no significant problem was noted. Same thing with the leaks. Uh, there is not a good correlation. Many times patients will come on top of the mass leaks all the time, but the reports don't show. And other times reports show a lot of leak, but the patient says, oh, it does not leak. In my opinion, main purpose of download is see the patient is compliant for the insurance purposes. I really feel hard pressed to make any major therapeutic decisions based on the download. Sometimes when AHI is really high, I may try to adjust the pressure, and that may benefit. That could might have guessed it without the information also. I'm not sure what your experience has been and what you have been doing with the download, but I feel that it's a limited benefit. There's another thing that in RISMED, at least you can see, which normally is not a part of compliance report. And if you look at this is from a night to night basis, and there are interruptions. There's a kind of a white line you see in between, which again is showing there's an interruption in the app use, which if you look at the compliance report itself will not tell you. In the RISMED, you can also look at some detailed data, which is somewhat helpful. Most of the time, you can go only 7 days from the date you're looking at, and it can tell you the pressure as it varies through the night, as well as the leak. And sometimes if it's an auto-titrating machine and you're hitting the ceiling, it can tell you that we need to go up on the pressure if it's ceiling, and that's when the patient is waking up or there's an interruption in the therapy. So looking at how to exclude alternate etiologies, again, going to the sleep history. One thing that I found somewhat helpful, and some of my patients will bring this information on their cell phone from Fitbit or from the phone app itself, the sleep data, which gives the quality of the sleep. And sometimes that's helpful. Keeping a sleep journal is also helpful in evaluating these patients. Again, insufficient sleep is probably the most likely reason, and encouraging patients to have good sleep hygiene. Look at the medications, see which could be making them sleepy. Sometimes looking at thyroid function tests in these situations. Several years ago, we used to do thyroid function testing on anybody suspected of sleep apnea, but we've gotten away from that. But now when the patients with sleep apnea have been treated adequately and still sleepy, certainly it's important to exclude hypothyroidism. If they have narcolepsy or idiopathic hypersomnolence, doing a sleep study with an MSLT testing would be helpful. It's not uncommon to have patients with obstructive sleep apnea and narcolepsy. So when you do a sleep study on these patients, several questions come in mind. How much pressure should you use this patient, or how much pressure the CPAP should be adjusted at when they are using during the sleep study? As we know, a lot of times our patients are using auto-titrating CPAP machine, and many times a range of 5 to 20 centimeters. To figure out how much pressure is somewhat hard. In my experience and my practice is that if their AHI is less than 5, I usually pick the pressure at 95th percentile, which many times download will give me that pressure. Otherwise, just pick a number, 10, 12, 14, if I don't have that information from download. I'm not aware of any lab using auto-titrating CPAP machines to do the sleep study. Maybe the labs you have do it. I'm not aware of it. Second question becomes is that should the pressure be titrated on the study? Most of the time, I instruct my techs to not to titrate unless there are clear-cut apneas on the pressure. And the reason being that if you undergo titration or retitration on this patient, then certainly we cannot do an MSLT after that, and that should not be done. And when we do the sleep study, looking at several things, including sleep latencies, if the patient has periodic leg movement disorder and have spontaneous arousals or arousals with the leg movement. And when we do multiple sleep latency tests, it's always a question, should they use CPAP during that time or not? Most of the time in my practice, I've not been using it, but if a patient wants to use it, it's perfectly all right to do that. So when we're trying to adjust the positive airway pressure therapy, what factors to look at? Certainly adjusting the pressure. Many times patient may tell the pressure is too high or too low, or if they're having a lot of burping or passing gas. Changing the mask or refitting the mask can make a difference. If somebody is not sleeping very well or has insufficient sleep or waking up a lot, one may consider a small dose hypnotic for a short period to see if that'll improve their sleep quality at night so that they're not tired, sleepy during the daytime. If someone has restless leg syndrome, periodic leg movement disorder, then certainly consider treatment for those conditions and consider alternative treatment for obstructive sleep apnea if applicable, certainly using an oral appliance therapy, considering hypoglossal nerve stimulation, or a maxillomandibular advancement therapy. There are certain medications that are available which can be used to treat residual excessive sleepiness in patients with sleep apnea who are treated with positive airway pressure therapy. Probably the most common ones are Provigil and Nuvigil, which is modafinil and R-modafinil. They do promote wakefulness in early evening and reduce Epworth Sleepiness score at 2.5. They do improve productivity, activity, and vigilance, and they do not disturb nighttime sleep. The most common side effect is headache. Sometimes they can cause chest pain or palpitations. They may reduce effectiveness of oral contraceptive pills, so they should be used in caution in women using hormones as contraception. Their exact mechanism of action is not known. Most likely they enhance that signaling of dopamine. Recently, there is another medication that has come out called solriamfetol, which is sold under broad brand name Sunosi. It also improves wakefulness, and it's an oral selective dopamine and norepinephrine reuptake inhibitor. Another medication which currently is approved for narcolepsy, but maybe will be approved for sleep apnea patients also in future. It's pitolisant or Wakix. This is a histamine receptor 3 antagonist, which is being tried. This is in brief about evaluation management of residual excessive sleepiness in patients with obstructive sleep apnea who have been treated with positive airway pressure therapy. Any questions?
Welcome to the Q&A portion of Dr. Jain's lecture. Dr. Jain, thanks so much for joining us.
You're welcome.
It was a great lecture. There was a lot of interest and a lot of questions submitted, so we will jump into that in just a moment. Before we do that, I just want to remind all of our participants, if you do need to complete the survey to get your certification, if you have not gotten the pop-up during any of the sessions, you can go to the lobby within this portal and you can click on the link to get you to the SurveyMonkey to complete that. However, you should start to see the pop-ups during each lecture approximately 30 minutes into the view. So just to answer some of those questions, but without further ado, Dr. Jain, let's jump in. We have a few really interested participants with questions submitted. The first question that we have, insufficient controlled sleep versus too much sleep. Are there any studies that compare the ideal restfulness?
Well, there is no magic number for everyone, and it's like how our brain is programmed, I guess, through the life and everything. There are several people who live on 4 hours of sleep all their life, and then other people who need 10 hours. So it's what is normal for everyone is going to be different. Average, I would say, is about 7 to 7.5 hours of good quality sleep is good enough to feel rested.
Great, thank you. Another question, what is your hypnotic of choice for someone to get used to CPAP?
They have done some studies and they found that using Lunesta, 2 to 3 milligrams, has been the preferred hypnotic in those situations to get to use CPAP, preferably in for maybe 2 to 3 weeks, maybe 4 weeks maximum, and not more than that.
Great. How frequently do you see sleep physicians prescribing pharmacological therapy in addition to PAP therapy?
Well, I mean, I don't have a data for that. I can tell you about my practice. I probably have more than 1,000 patients with obstructive sleep apnea that I'm treating. I would say about 25% of people do complain of some residual sleepiness after positive pressure therapy. And in those, maybe about 10 to 15% where I would prescribe wakefulness promoting agent. Most of the time it's modafinil or armodafinil. And with the availability of Sunosi, we have started using that a little bit also.
Great, thank you. And there's a question going back to some of the things that you talked about in the beginning of your lecture. The Epworth Sleepiness Scale, it's a pretty subjective sleepiness scale. Why do you think it's so widely used?
Well, it's the best thing we have because there's no other way of measuring sleepiness. But it is very subjective. It's like a lot of times patients don't answer them, and then sometimes some people, or you're sitting in a car and going, do you fall asleep? Some people who don't go out in a car or drive for an hour or sit down after lunch because of work. So those situations don't always apply to everybody. And that's why some people, and actually I was listening to a talk by Dr. Atul Malhotra, he's at UC San Diego right now. He uses more of a functional outcome of sleep questionnaire, the FOSQ score. Although that's 30 questions, not that easy to administer, and that he feels gives a better idea about that what's the impact of sleep or lack of sleep in your daily life. It's done more as a research tool in clinical practice. I don't use it, and I really don't think anybody else uses it.
It sounds like it's a little bit of a trade-off of how expansive is too expansive to make sure that there are some questions asked versus being bypassed completely.
A lot of times I think it is patients will come and tell because Epworth score may be high, may be low, but then they'll tell you, okay, I'm doing good or I'm not doing good. A lot of times that's what matters most. And same thing even with the downloads, when we look at it, a lot of times we'll see PAP downloads where it's really high HI or high leaks and other things, and when you talk to patients, oh, I'm doing great. So in those situations, you really don't want to change anything based on the download alone. You need to look at the whole picture.
Great. Some other questions that are coming in, and these are more high level about patients just adapting to therapy, but it seems as though a lot of patients feel as though they're swallowing the positive airway pressure no matter what pressure that they're prescribed. Any suggestions for how that can be overcome?
Well, the problem of swallowing air is just because that as you're opening the posterior pharynx, this is where your trachea and the esophagus both are there. So some swallowing is bound to happen. Some people have tried using bilevel as compared to a fixed pressure and feel that may help. I have not found that to be very helpful. What I found is helpful is that changing the angle of the neck at which you're sleeping. So if you make the angle a little bit more acute or less acute, that at times has helped. That by doing using an extra pillow or taking a pillow off, depending on how you're sleeping. So sometimes that can help, or reducing the pressure. There is no other magic treatment for swallowing air.
Great. Yeah, it sounds like positioning really matters. So that's a great tip.
It's a matter of the position. That's all it is.
Understood. Can a slight high thyroid affect sleep, or would treatment benefit high thyroid?
Well, if somebody is hyperthyroid, as we know that these people are more hyperactive and anxious. Certainly, that would affect their sleep quality. They probably will have a hard time falling asleep, and at times they wake up a lot through the night because of anxiety reasons. Now, if it's slight, it may not make that much difference. But if they are having other symptoms, daytime symptoms, beside only the sleep symptoms, then that probably should be treated.
Great. Dr. Jain, would use of oxygen in early days of PAP therapy be assistive in overcoming some of the long-term effects of hypoxia?
I didn't get the question. Can you repeat it again, Josh?
Sure. Would the use of oxygen in the beginning stages of PAP therapy be helpful in patients overcoming their long-term effects in hypoxia?
Well, again, the effects, what we see in people with sleep apnea as to their neurocognitive deficits, we are not entirely sure. What's the reason for those? Certainly intermittent hypoxia or autonomic dysregulation, neuronal damage, and all those things could be different reasons. And as I mentioned in some of the studies, they have looked at it that some changes may reverse as the time goes on. And some changes never will reverse. Now, using supplemental oxygen for first 2 weeks or a month or 2 months, I'm not aware of if anybody has studied that or not. But once you put them on a positive pressure therapy, one can document, do pulse oximetry or something to make sure they have adequate oxygenation. And if that's the case, then I'm really not sure if hyperoxygenating them would make any difference. I have my doubts. I'm not sure. I mean, I have not come across any studies. I don't know if anybody else has looked at this or not. And this is not an approved practice. And like these days, we kind of practice pretty much in the insurance guidelines. So it'll be very difficult to get it approved. If especially if these people did not show hypoxia persistent hypoxia, I should say, during the CPAP titration study.
Great.
Even if you ever get to do it, these days you don't even get to do titration studies.
Sure. Certainly in a world that we live in today, those are even more challenging. So thanks for those remarks. And Dr. Jain, that actually concludes the portion of the question and answer. We can't thank you enough for being a part of today's event and sharing it with all of our participants. So thank you so much. And in the next minute, we'll get started with our keynote address. Thanks again, Dr. Jain.
Thank you.